Hello, I'm Dr. William Sonstein of NSPC Brain and Spine Surgery.
And I'm Rich Obedian of Island Spine and Sports.
Welcome to our second recording of our podcast, The Spine Bros. And we're here to talk about things that are on our mind regarding spine surgery and spine management.
Well, last time we talked about cervical problems, including cervical disc herniations and cervical stenosis. I thought today would be a good time to talk about lumbar disc herniations and a common problem called spondylolisthesis.
Spondylolisthesis, doesn't that mean in Greek slip spine?
That's exactly what it means.
And most people don't really understand that these terms that we use are actually just simple descriptions of the problem.
Well, I always tell my patients that medicine is just another language, and we just justify using these large words to justify our high fees.
Exactly. Well, unfortunately, that's not necessarily the case anymore.
Well, we're not getting paid anymore, but it is interesting. Spondylo is Greek for spine, and listhesis is slippage.
Exactly.
So spondylolisthesis is a slipped spine.
And spondylosis means just arthritis.
That's right. And spondylitis means inflammation of the spine. So there's all different. Anytime you add the word itis to a Greek word, it means inflammation. So appendicitis is inflammation of the appendix. Dermatitis, inflammation of your skin. Arthritis, inflammation of your joint. But let's get back to spondylolisthesis.
Spondylolisthesis, it's a very common problem. I certainly see spondylolisthesis pretty much every time I'm in the office. Patients come in with spondylolisthesis, and they wonder, what is that? And most people just think it's basically a herniated disc, and it's basically far from that in essence.
Right. It's more of an instability to the lower back. You can see it in other parts of the spine as well, but there are two main categories of spondylolisthesis, I would say. There's the most common, which is degenerative.
Degenerative, which is usually at the L4-5 level.
Right. And you can also see it at L5-S1.
You can also see it at L3-4 and L2-3, but most commonly it's at L4-5.
Right. And you can also see isthmic spondylolisthesis or a congenital type of spondylolisthesis.
And what is that generally?
Which there's a defect in the pars. The pars interarticularis, another fancy Greek word, which means the thing between the two joints.
Right.
That's
it's just a bridge. It's just a bridge. And the people, they have some sort of genetic predisposition. About 5% of the population actually has it. And they develop this crack, I'm going to call it, usually during their adolescent growth phase.
Yeah. Oftentimes we see it in girls who are gymnasts or boys who are football players. Oftentimes it's not diagnosed until they're much older.
It's really not a fracture. It's not like an acute type of fracture. It's a chronic gap, basically. It's also associated with sort of joints that are not competent, meaning that they don't hold the level of the segment properly. They're malshapen.
Yeah, it's a failure of development. It's a failure of the initial development of the spine anatomy.
There's always a lot of times there's an association with other defects,
like a bifid.
Opening in the back of the actual spine, there can be a gap, and that gap is sometimes associated with spondylolisthesis in L5-S1 variety, the congenital variety we see. The thing about these types of problems, generally, these types of problems affect not only the causing back pain, but they also can cause leg pain as well.
They can cause leg pain when there's pressure on the nerve or there's instability. Sometimes the leg pain is formed by certain motions that the patients make, especially extension. But sometimes even with flexion, they can get pain that shoots down their leg. Sometimes it can be bilateral. Sometimes it can be unilateral, depending on what side the pars fracture, the pars instability is.
Sometimes people just present with leg pain and not back pain, actually.
Absolutely. Although I would say back pain is more common with spondylolisthesis, as opposed to a herniated disc, where the most common feature is severe leg pain.
Oftentimes, at this gap, and what we see in the operating room is a thickening around this gap. Basically, it's sort of an inflammatory condition, and it causes the ligament and such to thicken around it, and often that drives the compression of the nerve actually and causes the actual pain down the leg.
It's the body's attempt to heal itself, so they form some scar tissue or some fibrous tissue around that pars defect, and that can thicken, like you said, and cause stenosis, which is the same stenosis we see in the cervical spine, which is just a narrowing of the spinal canal. And the pressure on the spinal canal can then result in leg pain, numbness, weakness, tingling, and symptoms like that, which often bring them into the office because they used to be able to run or walk long periods, and now they're limited.
A lot of these patients, they always wonder, what is stenosis? And I just tell them it's a fancy word. It means narrowing from any reason.
Yeah, for any reason. A lot, and there's when you're in medical school, they teach you about differential diagnosis, and causes of leg pain can be neurogenic, which means that it's coming from your spine, but they can also be vascular. So it's very important to distinguish between vascular and neurogenic claudication. And one interesting way to do that is ask the patient, do you feel better when you're leaning forward, such as when you're pushing a shopping cart?
Or when you're riding a bike.
Exactly.
Or when you sit down.
Right. And patients with vascular problems, they have leg pain no matter what their position is. Doesn't matter if they're riding a bike or they're standing up straight. Their leg pain is constant with activity.
It's really not a positional sort of thing.
Correct. So that's one way. If you have any question, you can always send them to a vascular surgeon who can do the appropriate studies.
Them. Yeah.
Yeah. But so now you have this patient who comes in, like, for example, I have recently we had a 50-year-old woman who came into the office complaining of severe back pain, which was interestingly only radiating down her right leg. It had been going on for, I would say, at least 6 weeks before she came in to see us. She had some chronic back pain before that, but in the 6 weeks prior, she was doing a yoga exercise where she was doing something called a bridge. I guess that's like some type of...
Is that sort of a reverse plank?
That's about, I don't know what that means, but yeah, that's probably what it is.
Yeah, I haven't really...
She was doing some hyperflexion exercise of her spine, and she said she felt a pop in her back.
Right.
And then it was immediately followed by severe pain shooting down her right leg.
I mean, that usually indicates, in my experience, a patient with a herniated disc.
That's a classic finding for a herniated disc. And what's interesting about this particular patient is that she had originally gone to one of these ortho emergency rooms, Ortho Express, and they got x-rays and told her she had a spondylolisthesis, which she did. She had an L4, L5 grade 1 spondy.
Did she have stenosis associated with that?
A little bit.
I think that she, oftentimes these patients have, with the spondylolisthesis, they oftentimes do have this stenosis, and that's just narrowing due to arthritis. And it's usually due to enlargement of the joint and thickening of the normal ligament that's there. And I always try to explain to patients that arthritis is the spine or the body's attempt to auto-stabilize itself. And when it senses there is some instability, whether it's degeneration of the cartilage or the ligamentum, what we call laxity, just chronic instability, not acute instability where the patient will sort of fall apart, but it's actually just chronic lack of supporting structures, if you will. And the body tries to do something about it. It tries to make something to help stabilize itself, and that usually results in enlargement of these joints and thickening of the ligament, and the nerves become collateral damage because these things that are made cause stenosis or cause narrowing of that canal secondarily.
Right. So you would think that somebody who had this spondylolisthesis for much of her life, probably since she was a teenager, would have been symptomatic for that and would have had leg pain before. But this reverse plank that she was doing probably, I agree with you, caused something else to happen that gave her acute pain only down the right leg.
Well, I think a lot of people that have this stenosis can live with stenosis almost to the point where they have no spinal canal left. It's important, I think, also to remember that patients oftentimes come in and they think their spinal cord's being compressed in the lower lumbar area, and that's simply not true because the spinal cord
ends at L1.
It ends at L1. The spinal cord does not continue down to the bottom of the spine.
Right.
So that's one thing that people have to understand. They always think they're going to be paralyzed or not, but the reason why they're not paralyzed is because the nerves, unlike the spinal cord, they can take chronic compression for a long time and accommodate that.
Right.
And that's why these people come in with very severe narrowing of their canal, but they're completely intact neurologically, and they may have some symptoms,
right,
but they may not.
It's different from the neck. If you have severe stenosis in the neck, you can get myelopathy and compression of the spinal cord. But once you're below the L1 level, there's really no involvement of the spinal cord, and you're really just affecting the nerve roots, which can be serious too. You can get problems, if it's long enough or acute enough, you can get called Aquinas syndrome.
You get a foot drop.
You can get a foot drop. You can get problems going to the bathroom. You can get a whole host of annoyances that really interrupt your life. So then they're not to be taken lightly, even though there's no pressure on the spinal cord. So in this case, we got an MRI of her lower back, and surprisingly, not only did she have an L4-5 grade 1 spondy, which caused stenosis, but she also had a significant right-sided L5-S1 herniated disc.
And I think that's maybe what brought her over the edge.
Absolutely. So herniated discs probably were, it's a very classic story. You had some lower back pain, and then you did some kind of activity where you increased the intra-abdominal pressure on that disc, and then the nucleus popped out of that disc through the annulus and caused the severe leg pain.
The disc is like a jelly donut.
Right.
And the donut part basically gets a rent, yeah, and it probably wouldn't taste very good. To me, it looks like a herniated disc in the middle of the in the operating room. Looks like a lump of crab meat.
Yeah, that's exactly what it looks like. I don't eat crab meat, but that's what it looks like.
You wouldn't know.
I wouldn't know.
But that's okay.
Yeah.
It's described.
So yeah, the annulus is a different type of collagen. It's a type 1 collagen. That's thicker, more rubbery kind of a collagen. And when that gets a crack, and as people age, sometimes with increased pressure, that inner disc, which is a type 2 collagen, which is much softer, can leak out. And that leakage is the herniated nucleus pulposus, or the HNP, what we all call, in lay terms, a herniated disc.
And that can set off a whole biochemical cascade where when that change of environment happens from that herniated disc, when that type 2 collagen comes out, as you describe, that changes the way the environment is, and a lot of different cells and mediators that cause pain come into play in that area.
Right. So it causes a lot of inflammation because it's not meant to be there. People have been getting herniated discs for thousands of years. Before we had MRIs or CT scans or other imaging modalities to diagnose them. And your body would try to heal itself. So you would create a cascade of inflammation and try to wall off that disc. And over time, your body would hopefully remove that disc. So over time, it will probably shrink if you can deal with the pain.
Discs are very dynamic. They can actually get worse, and they sometimes can involute and actually disappear.
Yeah. What do you think caused that involution? Because there's some chiropractors will say because of their procedure, they were able to put the disc back into its place as opposed to it just disappearing by itself.
I mean, it depends on how far out the disc goes, and it also depends on the state of hydration of that disc, how hydrated that disc is. Like any other thing in the body where the body takes care of it, basically a blood clot in your arm or a hematoma or bruise, it gets reabsorbed. So oftentimes that same process can happen actually with a herniated disc.
But I don't think it's going back to that disc space. I think once that disc leaves that disc space, it's not going back.
It doesn't want to, because now you have a load on the spine that's actually causing and driving that disc to stay out of the actual.
Right. Your body's absorbing it and releasing enzymes to destroy it, but it's not going to go back into that space.
I think what can happen is that sometimes the treatment, the conservative treatment with chiropractors, is that they oftentimes try to distract or basically stretch out that person and try to, if the disc is contained, then perhaps, the ligament that basically surrounds it or it's containing it can actually be stretched and cause the disc to have less of an effect on the actual nerve.
Maybe. I'm not convinced, though. I'm not convinced that a disc is going to pop back into place. I think people who get MRIs afterward that show the disc has regressed, it's really more a function of time and the body healing itself
exactly.
than any manipulation.
Getting rid of that acute inflammation. That's why we send patients for injections sometimes, the epidurals, because those epidurals can sometimes reduce the inflammation, or with the steroid actually is an anti-inflammatory, can reduce that inflammation and relieve the acute pain. I think those patients do very well with epidural sometimes as a conservative treatment of the
Right. Problem. So what we did in this woman's case was we initially didn't recommend surgery right away to her. We recommended that she try a back brace for the spondylolisthesis.
You mean you're a surgeon and you don't recommend surgery right away when you see that patient?
It's the funny thing is, I'd say the vast majority of our patients don't go for operations.
I'd say that's absolutely true.
Because 9 out of 10 people with a herniated disc will get better without surgery.
That's right, especially in the neck and the back.
And you got to give them some time and be patient.
Time is the best healer of all.
If a surgeon's rushing you to the operating room, I'd get another opinion, unless there's a neurological deficit or a Cauda-Equina type syndrome. In general, these things you can be a little patient. I wouldn't wait 6 months. But you can definitely wait at least 6 weeks to see if they're going to improve before they start developing serious problems.
Right. So you have to follow these people really closely.
So we did exactly what you recommended. We gave her a back brace. We started her on physical therapy. She also had a chiropractor she wanted to see, and she was and we have no problem with patients seeing chiropractors. Some people like their chiropractors better than the physical therapist, and vice versa. So
people take their advice from their chiropractors and their primary doctors.
Yeah, because they see them on a more daily basis. They're seeing them 3 or 4 days a week, and they get to really know the patients very well. So, and they trust them because they become almost like their friend.
Right. We're sometimes viewed as almost like the enemy of the patients because we want to cut and we want to basically, get them into the operating room. But that's actually not the way we handle patients in our practice.
No, we are very conservative. That's why we have good relationships, I think, with physical therapists and with chiropractors and other patients because we don't run to the operating room immediately.
And I think I think that most patients in general resolve a lot of their symptoms. And it's also good to have relationships with these doctors because let's face it, we have to somehow get some patients.
What do you think is the pain generated when somebody's got a herniated disc? Do you think it's coming more from the actual pressure of that disc on the nerve, or do you think it's coming more from the inflammation that your body uses to try to remove that disc?
I think it's both.
It's a combination.
It depends on how the size of the disc. I mean, some people can have a small focal disc herniation or a little disc herniation and have symptoms that are way out of proportion to the size. But I think that it depends on the inflammatory response that occurs as a result of the release of the type 2 collagen into the actual canal where the nerve is.
Well, disc herniations are like real estate. Location is really, really important. You can have a small disc herniation that's pressing directly on that nerve root, and the patients are in agony.
It's tight in there. That's why spine surgery is so much harder than brain surgery because you have so little space to work in.
Right, and then you can have a large disc herniation that's
controversial if you speak to a brain surgeon, of course.
They don't like to hear that.
Well, I know.
Everybody thinks the brain surgeon is the highest of the high.
You have more room in the brain to work around. The brain, you can touch the brain, you can feel the brain. When you operate.
It's more forgiving.
Spine, you really have very little room for error.
And plus, when you go into a brain operation, people are expecting to come out as a vegetable. So if you come out semi-intact, people think you did a great job.
Well, you have to.
As opposed to spine, where they expect perfection every single time.
Right. Well, I think that these days, they expect perfection no matter what you do, actually. But that's fine.
We have a high standard.
We have to basically do a very high level with these types of things.
Unlike baseball players who have to be right 1 out of every 3 times and they make the Hall of Fame, you got to be right 99.9% of the time.
We don't get necessarily second chances with these cases. We have to do them right the first time.
That's very true. That's very true.
That's why it's very important for us to discuss it. That's why I think our relationship is actually quite good at working as a team because we discuss these cases. We're giving the patient basically 2 opinions and coming up with a plan together, not just one-sided, which is good.
I was thinking about it, having a neurosurgeon and orthopedic surgeon work together. And the very first reported case of a herniated disc in the New England Journal of Medicine was written by Mixter and Barr.
In 1936.
I think
it was 1936.
Around that time. Before we were born.
Weren't they neurosurgeons?
No. Mixter was a neurosurgeon and Barr was an orthopedic surgeon.
They were not.
Mixter was the chairman at Mass General,
Okay.
Man's greatest hospital, and MGH. And Barr was an instructor in orthopedic surgery at MGH.
I think that's a very good a story to tell patients actually when they come in for a herniated disc.
About Mixter and Barr.
The fact that there was a collaboration between an orthopedic and neurosurgeon. Absolutely.
Patients like that as an option. Sometimes you go into these renowned hospitals, and the person who you think is going to be doing your operation is actually only there for a short time because they have other rooms going on or they're distracted, and really the fellow or the resident is actually the one who's doing the case.
Exactly. I mean, and at least in our practice, I've always encouraged all the doctors that came aboard over time to make relationship with the orthopedic surgeon and work with an orthopedic surgeon. So I think the case is essentially you're giving the patient the best of both worlds, and their treatment.
It's a good strategy. I mean, plus it's good in the operating room to have another experienced hands and eyes to look at a problem. Did we get enough of the disc out? Let's check. You see from a different angle.
Right.
You can make sure that you've actually removed the herniated disc. So that they don't get a recurrent herniated disc afterwards.
Right.
You didn't miss it. You didn't miss any disc material, and you've really decompressed them adequately so they don't become or get a recurrent disc.
Right, because you have another person there who understands, and can feel and know, all the different regions to actually check around the nerves to make sure that there's nothing left. Whereas a PA, which are perfectly fine to help, but they may not have the experience to know how to check certain things. So it is good, I think, to have two attendings working on a patient.
Absolutely, absolutely.
At least in our practice, the way it works, I think it's the best for the patient.
So this woman actually ended up going for the physical therapy. She saw a chiropractor, tried the brace. Nothing was really helping her. And we sent her to pain management to consider an epidural steroid injection. And like you said before, there's a lot of inflammation that's created when there's a herniated disc and an acute situation. And by giving the steroid directly into the spinal cavity, you can reduce that inflammation and hopefully stop their pain.
Did she have any response to that epidural?
Didn't do anything for her.
Didn't do anything. Okay.
No, she was miserable even after the epidural.
So she's pretty much tried all means of conservative management at that point.
She has. So at that point, we recommended surgery for her. Now, what do you generally recommend for an operation for somebody who has, let's say she only has a spondylolisthesis? Do you generally do a decompression with a fusion?
I think that this is probably one of the most studied problems in spine surgery, degenerative, particularly degenerative spondylolisthesis. I think the community standard and what has come up as a result of studying this is that you should offer a patient a fusion as well. And that method of using, whether you use instrumentation or with bone graft material, because you have to put the bone graft material down. You can't.
That's really the key, is the bone graft material.
Because when patients, they don't understand that a fusion is it's not a nuclear fusion. It is basically to connect the two segments together to basically prevent any abnormal motion in the future, so that drive to make more arthritis is arrested. So the fusion is actually a good thing for these patients. Now, there are many considerations for doing a fusion. You do end up putting more stress on the segments above and below, but sometimes these patients already have an area that's not working properly anyway, and then the levels above and below it are actually starting to take over for that level anyway. So they already have more stress on them at the time when you would consider doing surgery on these patients. Right. The question is sometimes whether you use instrumentation or not. That has never been proven to be, one way or the other. The only thing I think that has come out of the studies is that instrumentation will improve the fusion rate.
Absolutely. But you've got to select your patients carefully when you decide to do a fusion with instrumentation. Patients who are elderly or more osteoporotic, I'm a little more hesitant to do a fusion with instrumentation. So you can do what's called an in situ fusion in those kind of cases, where you do a fusion with just the bone graft and without putting any screws in.
And yes.
And surprisingly, patients are very they like that idea.
They like the fact that
they don't like the idea of having metal in their body. Metal is a foreign body and it's got a bad reputation. Although the metal that we use is titanium, and you can still get an MRI afterwards. It's not going to set up a metal detector. It's not magnetic, but still, not having metal is very appealing to a lot of patients.
It's just one less thing for us to worry about as well in the future, because we always worry about instrumentation and making sure that it not only does not loosen, but it doesn't move or cause a problem. And it also adds time in the operating room too. It's nice to do an in situ fusion, because once you do the decompression, which is really the most important part of the surgery and probably the most difficult part of the surgery, to put on bone graft on the sides it really takes very little time.
Yeah, and truthfully, putting in the screws generally is pretty. It adds maybe 15 more minutes to the operative.
It's pretty straightforward.
Pretty straightforward, because we've
been doing it for a while.
We have a good experience with that. So if you need screws, it's really not the end of the world, and it's actually probably beneficial to get those screws.
The patients they do have an issue with it, and it's funny because orthopedic surgeons use metal all over the body. They don't seem to have a problem with that, but when it comes to the spine, they seem to have a problem with the metal.
Yeah, I think spine surgery in generally has a bad rap in the public, because people see people who are going for multiple operations, they're not getting better. With each operation, there's more chance of a complication, and that goes back to your original point, which is you want to do the right thing from the get-go. So doing a isolated laminectomy for somebody with a spondylolisthesis might make them feel better temporarily, but in the long run, there's a good likelihood that you're going to make that level unstable, and their spondy can progress and go from a grade 1 to a grade 2.
And they can redevelop stenosis.
They get recurrent back pain and recurrent leg pain. and then you've got to do a second operation. And
second operation is not always.
It's not as easy as the first operation.
You want to do
pleasant. You want to do it right the first time. There's scar tissue involved. There's a higher chance of infection. There's a higher chance of the dreaded spinal fluid leak. There's higher chance of multiple complications with these patients when they go back and forth with each successive time.
We talk about a spinal fluid leak, and we like to avoid it like the plague in our practice.
Pretty much.
But it's something that happens if you do enough surgery. Inevitably will happen to a patient, particularly those patients who've had prior surgery. The risk becomes higher. Patients who have I'm going to call a virgin back, who've never had surgery, the planes are much easier to separate, and you're less likely to get a leak.
There's less scar tissue. When you're separating that scar tissue from the underlying dura, you can inadvertently sometimes get a small leak, and that can be a problem. It can be a big leak as well.
And they're not, and they're not always so straightforward leaks to fix, because sometimes they're in locations that are difficult angles and things like that. So we really try to avoid getting a leak. But if there's a leak, we have to fix it at the time of surgery, and we just suture it up and we put down some glue.
Yeah, it's not like Elmer's glue. It's a
biological glue.
Right.
It's a biological glue based on thrombin, and it forms sort of a
clot,
thickened clot, essentially, a clear clot that essentially seals off that leak. But the problem with that is that the patient has to stay down for a couple of days, and it basically prolongs their stay in the hospital, which is not ideal.
It definitely does. So this woman ended up going for the surgery, and we ended up doing an L4-S1 decompression with a fusion, with instrumentation, and we did a discectomy on the right side of the L5-S1 level, where a large extruded disc was removed. And that disc, I think, was probably the cause of that severe right leg pain, coupled with the stenosis that she had.
And I think that at that time, to just do the disc and not address the stenosis and the spondylolisthesis, I think would have been wrong, because if she developed symptoms from the stenosis and the spondylolisthesis, let's say you made the assumption only to address the discectomy and do a smaller operation, I think that, and she came back again 6 months later with symptoms referable to the L4-5 level, then you have to go into a patient who has scar.
Yeah. And like you said, it's much better to do it as a virgin back and do it right the first time. And she's, I just saw her last week. She's doing very well. X-rays look excellent. Her right leg pain is dramatically better. She had numbness and weakness in her leg that is also dramatically improved.
Well, there you go.
So another success for the Spine Bros.
For the Spine Bros. Good.
And then that brings us to another patient who had, she was a 62-year-old woman who came to the office complaining of severe left leg pain. And she'd had this pain for about 2 years now. She's getting some numbness and tingling, some weakness in her foot, some difficulty with walking. And she had really tried everything to deal with this pain. And she was unsuccessful. She had gone to a chiropractor. She had gone to a physical therapist. She had tried acupuncture. She had actually gone to India. Listen to this one.
India.
She went to India, and she underwent a series of spice enemas.
Spice enemas.
To treat the inflammation in her back.
And how did that work out?
And she said that when she got the spice enemas, the leg pain was dramatically better.
Well, I mean, things get absorbed very well through the rectum.
But it was short-lived, unfortunately, for her. And we got a new MRI of her lower back that showed a massive left-sided L5-S1 herniated disc. And I think her daughter was planning on getting married in about a month or so. And so we offered her surgery. And she actually initially did incredibly well.
Didn't she have an epidural first, I think?
She had multiple epidurals as well. In addition to the enemas and the acupuncture, nothing was helping.
I think what we tried to do, actually, if I recall, we tried to get her to her daughter's wedding
in New Mexico. Which is coming up. It's in a few weeks.
She was worried about she was very worried about making it to the wedding, having surgery before. So we said, okay, let's try an epidural and see if we can get you through that. And it just didn't work out, and she was miserable. So she wanted to have
and that was actually her third epidural. So she had really exhausted all non-operative treatment. And we took her to the operating room. She had a large left-sided L5-S1 disc herniation. We did a hemilaminectomy. removed that herniated disc.
What is a hemilaminectomy?
We didn't do a complete laminectomy. We just did a hemi, or a half of a laminectomy, just on the left side.
Just on one side, so we preserved all the tissues on the opposite
Correct.
side. So it's a much smaller operation in essence.
Yeah, much quicker recovery, and we were able to remove a massive, multiple fragments, but one very large one and several others, decent-sized fragments from the L5S1 disc.
Do you take out the whole disc when you remove?
No, we only remove the portion that's herniated.
Right. Most patients don't understand that. They think we're just going to remove their whole disc, and then they say, "Well, what are you going to put in its place?" I always tell patients, we just take out the part that's pressing.
That's right. That's right. I mean, sometimes when we do a fusion on somebody, we'll do something called an interbody fusion, where we actually will put a spacer, either a bone spacer or a metallic spacer, into that disc space. But that's when we take out the entire disc, and that's called an interbody fusion, or posterior lumbar interbody fusion, or PLIF for short.
We usually like to, or actually some people like to go more off to the side to be even safer with their approach, and they call it a TLIF, or transforaminal. It's basically, it ends up being the same thing. You put a bone graft or a cage or metal, you fill it with bone in that space, and that essentially prevents the disc from ever reherniating again. Sometimes we choose that operation just for patients who've had disc removal initially, but then come back with a recurrent disc herniation, and they need surgery again. And to prevent them from ever having surgery again, we take out the whole disc.
Yeah, I think I would agree. We generally save PLIF and TLIF for patients with recurrent discs, so to prevent their collapse, because at that point there's not much disc left there anyway, and you can get up-down stenosis, which is another. Or stenosis of the foramen, which can be caused by collapse of that disc space.
Right. The disc actually keeps the foramen, or the tunnel that the nerve goes through, open. So if they collapse down, they can get pressure on that nerve, which is not appreciated so much on certain cuts of the MRI, but it's happening, and that those patients can benefit by having that their anatomy essentially reestablished by opening up that space. A lot of those patients that we do that procedure on have a lot of back pain, chronic back pain. And those patients, it's obviously you have to look at each individual case, but those patients sometimes do benefit by initial interbody fusion. But I think for the patient who comes in, particularly the young patient who's pretty active, we would like to, if they just have mainly leg pain and disc herniation,
do a discectomy alone.
Just do the discectomy. I mean, there is a slight recurrence rate, about a 5% to 10% recurrence rate of a disc herniation, and you have to tell the patient that. But that's why when you go in the first time, you really got to make sure you explore and remove any loose fragments in that disc space.
Yeah, we often will irrigate that disc space profusely to get any loose fragments out, and we really explore we follow that nerve root down into the foramen and make sure that it's totally free before we stop.
When we do that discectomy, not only do we remove that disc fragment or the protrusion that's into the nerve, but we also have to, what we like to do is we open up the tunnel that the nerve goes through so that the nerve is free at that point.
That's called a foraminotomy.
Foraminotomy. Even if the disc, in essence, recurs, they have all that room to, and essentially there's a little more forgiveness there for that nerve.
Yeah. When in that rare 5 to 10% chance of a recurrent disc, it's a very difficult thing to diagnose sometimes, because when you get an MRI postoperatively, there's so much inflammation and postoperative changes that it's sometimes very hard to tell if they have a recurrent disc versus scar tissue there.
Right, and that's the problem with getting an immediate MRI after a person has still some pain afterward, and you're worried, did the patient have a recurrent disc or not enough disc was removed?
Right. Generally, their pain goes away very quickly. There are some patients who have such severe compression. I remember in this particular patient, when we went in there, she had a very battered nerve. It was really red.
It was very battered.
It was crushed, and it was clearly under a lot of stress. And sometimes those patients can take a little while longer to get recovery of that nerve root. Nerve roots are unlike the spinal cord or the brain in that they can recover.
That's
right. The nerve grows back. It goes back slowly, but it comes back about 1 millimeter per day. So it can take up to a year.
Yep.
To really get your sensation back, and it may not come back 100%. And as same with the weakness, but generally the pain gets better very quickly.
You hope that the patient gets better very quickly. You hope that the pain is somewhat improved, at least initially. In other words, patients who who have no improvement after surgery from removing a massive fragment, you have to sometimes wonder, is there something left? But you're hoping at least they get some improvement so you can still wait it out, and hopefully they will get full improvement or much, much improved.
Yeah, that's why I don't like rushing to an MRI post-op after a discectomy.
If you do have to get an MRI and you're really concerned, you can give them contrast, and that can differentiate between scar and the actual disc, because disc does not take up contrast material.
That's right. So the disc will light up with the. I mean, the scar will light up with the gadolinium.
That's right.
And the disc will not. So that's how you can distinguish between the two. So you get an MRI with gadolinium,
which is pretty safe.
Yeah, there were some reports of some renal problems after getting gadolinium. So I think now the radiology MRI places are requiring labs to make sure they have good renal function, good creatinine levels, and they can go for an MRI with contrast.
Yeah, fortunately, I don't recall too many patients ever having a problem with gadolinium in terms of their kidney function.
Yeah, it's pretty rare.
So we can give that.
Yeah, and there are some reports that with the newer techniques of MRI, they're able to distinguish better by playing with some of the stir images and things like that to see to try to distinguish between disc material versus scar tissue.
You have to go to a high quality MRI place, and there's a variation of quality that we see all over the place with MRIs. So you really want to get to a place that has at least a 3 Tesla unit, as far as I'm concerned, because then you're left with an MRI you can't make a decision about, and then sometimes you have to end up repeating the MRI.
Yeah, and it's also important to be able to read the MRIs yourself, because a lot of the radiologists might miss something or misinterpret something. We see that all the time.
Sometimes they overread things, I think.
They overread things. Sometimes they underread things. And it's really incumbent upon us to look at our imaging studies before we operate on somebody and look at it and be convinced that we agree with what the radiologist thought. And that's why it's also good to have another spine-trained neurosurgeon or a spine-trained orthopedic surgeon to review the imaging studies beforehand, so that we all agree this is the pain generator.
I mean, sometimes I will call based on the reports. I'll call the radiologist and ask them, can you take a look at this again? And sometimes they agree, sometimes they don't agree. But if they do agree, that's perhaps maybe they'll reword it, or they'll add an addendum, which is good for everybody to know, how everybody feels about that report.
It depends on their level of experience, and they're people, radiologists, so they might be
they read a lot
of films in one day, and they may have missed something subtle that we're very attuned to, because we're trying to make a decision regarding surgery. So we really want to look at it in a much more in-depth way.
Sometimes reports, they'll read a certain spinal level, and we'll disagree with that. Sometimes what happens is that the bone, particularly at L5, will look more like the sacrum.
Right, they call that a transitional segment.
It's called a transitional segment, and they'll call something L4-5 when we're calling it L5-S1, or L5-S1 when it's L4-5. So we always have to know what level we are talking about, and when we go into the operating room, we always get an X-ray confirming that level prior to initiating a surgical treatment.
It's a good point, because I've had that conversation many times with the radiologist, and they'll argue with me and say, "Well, if you count from C2 down, it's actually it's a different level than what you're thinking." And what I always tell them is, "Well, we're in the operating room. We don't have that luxury of counting from
we can't do an X-ray.
We're looking at the sacrum and L5. So we for our purposes, what you're saying is, the other level, we're going to call that L5-S1.
But we have to
be in agreement as to what the correct level is.
That's right. We have to know what we're specifically saying is that level.
Yeah.
And that's important.
That's one of the most common reasons spine surgeons get sued. It's operating on the wrong level.
Well, to me, that is something that will never, ever, hopefully, ever happen in my career as well as yours.
Yeah, no, we are really
pretty insane about that.
Yeah, we go crazy.
We'll even argue, because sometimes the imaging is not great in the operating room, and I'm like, I really think that's L5-S1. No, it's clearly, And so we have to make sure we are on the same page every time we do this type of surgery to know exactly. That is something that has to be avoided, operating ever at the wrong level.
Yeah, we are compulsive about the level.
Now, sometimes in the operating room, we'll see something that we feel needs to be addressed that we didn't necessarily think about it at the time of the patients seeing them in the office.
Right. Well, when I consent a patient for the operation, I always tell them that if anything should arise during the operation that we encounter that we didn't expect, Sometimes that can change the operative plan before. We might have to do additional levels. We might have to fuse more than what we thought. Sometimes we're planning on only doing a laminectomy, and we get in there and we might see a pars defect that was undiagnosed before.
And
that's happened before.
We've seen that before.
Yeah, that's happened before. I had one patient who had a discectomy, and she had done quite well, and then developed a traumatic pars fracture.
How did you get that?
She got hit by a door.
How does that happen?
It was a very heavy door.
It must have been,
and it knocked her down.
It must have been a steel door.
Yeah, it was a very heavy door, and it was a crazy situation because that fleck of bone from the pars interarticularis that fractured during her getting hit by the door and causing her to fall punctured her dura. So she had a traumatic CSF leak, and this is about 6 weeks after her discectomy. So we took her back to the operating room with the plan, and she couldn't even tolerate going for an MRI or any more imaging studies, but she clearly had all the signs of a CSF leak, which include a headache, photophobia, fear of the light was bothering her eyes. It was very positional, and she had a lump in her back that was consistent with a fluid leak. So we took her back to the operating room, explored the wound, saw the CSF leak, but also saw this pars fracture that was unsuspected. That was probably the cause of it. And we did what's called an in situ fusion on her, where we basically put some bone graft down into that space to try to heal that pars fracture.
I guess it's possible that during the initial surgery, when you oftentimes have to take part of the joint to get to off to the side enough to get around the nerve to do your discectomy. It's possible it was a bit weakened. And then that door incident just
pushed her over the edge.
And gave her
a little She was also a little osteoporotic.
So that
didn't take much to push her over the edge. If you remove more than 50% of the facet joints bilaterally, that's generally causing iatrogenic instability or stability that's caused by the surgeon.
Sometimes you just have to do that to really adequately decompress the patient.
And then you really should fuse the patient. And most patients, if you tell them that you're going to do the right thing for them, they are happy, and they don't want to go back a second or a third time to do more surgery. It's a big deal to have a back operation. So generally they trust you, and they'll tell you, do what you think is right, doc. And we aim to do that. We don't try to do too much. We don't try to do too little. We try to do the right thing.
So initially you put down bone graft material, and there's materials now that are available to us because of advance in technology that actually we use oftentimes hormonally soaked sponges that actually can induce fusion with growth factors that actually cause the bone cells to fuse together.
Right. There's something called BMP, which stands for bone morphogenetic protein. And they're, like you said, there's these collagen sponges that are infused with this material, which is really a hormone that the body secretes to cause a fracture to heal. And when you want to, when you're doing a fusion, it's almost the same thing as creating a fracture. The same kind of biology is involved. And so you want to get that fusion to heal. So by adding the BMP, it will increase the chances, increase the likelihood of a fusion occurring, even without hardware.
That's why you feel that in those situations, you don't have to necessarily use hardware because you have BMP in the area where you want to induce a fusion.
Yeah, I mean, BMP is FDA approved for anterior lumbar interbody fusions, but sometimes we'll use it off-label usage in patients who are smokers or who have a high likelihood of failing for whatever reason, because they might be diabetic or have other medical conditions. So sometimes we'll use it in those cases, and you're absolutely right. Those patients fuse like gangbusters. They have a very high rate of fusion. They use it in orthopedic surgery for non-unions or fractures that are very slow or don't heal. And it's a really amazing thing. The U.S. government is one of the biggest investors, the Army, the military, in getting fractures to heal. And during the Vietnam War, we had a lot of veterans who were coming back from Vietnam who had fractures that weren't healing, and they ended up getting amputations, sadly. And so the U.S. military really invested millions and millions of dollars trying to discover ways to get these fractures to heal. And eventually it led to the discovery of BMP. But before that, they found that electrical stimulation across a non-unit, across a bone that's not healed, can accelerate healing.
The bone stimulators.
And so we use bone stimulators in spinal surgery for spinal fusions.
We used to use these
Implantable ones.
Implantable ones where you put a wire through the fusion mass.
Right.
And then the person connected to a battery that you actually essentially ran, and somewhat down the line, you take the battery out after they fuse. So the patient has to, unfortunately, had to go through a second surgery.
Right.
Which is not a big surgery, but still they have to.
Still, it's an operation. You know, I mean, you know the definition of a big operation?
What is the definition of a big operation?
Any operation done on you.
That's correct.
You know, minor operations can lead to big problems. So
anything, it can lead to an infection.
There are unforeseen things that can happen with any kind of surgery.
It's a foreign body in there. So then we had what we call external bone stimulators, where we put like a brace around the patient that actually has an electrical current that stimulates the bone mass.
And there are different companies that make them. Some of them are only 30 minutes a day. Some of them are a couple hours a day. But they seem to, you know, there's no problem in doing it. They don't cause any pain or any situation with the patient who gets a bone stimulator. But they seem to be helpful in accelerating healing in patients who undergo fusion operations. The
problem I find in those things is that a lot of times the patients are non-compliant because they have to change the battery charger, and they forget to do it, and they end up not using it every day, so it defeats the purpose of it.
Right. Well, the patient's got to be motivated for sure. For sure, they got to be motivated. I mean, there are other things that can prevent fusion from occurring. You know, cigarette smoking is one of them.
Yes.
Some of the medications that people will take can sometimes, like steroids,
radiation.
If they have chemotherapy, diabetics are slower to fuse. There are a whole host of risk factors that lead to non-union. And one reason why we put instrumentation in is that motion, too much motion, can prevent fusion from occurring.
Right.
So by stabilizing with the screws and the rods, you're preventing the motion and keeping it still, so that's more likely to fuse.
I tell patients it's like a cast for your spine, like a cast you would be for a broken arm. But the only difference is that you don't. If you have the instrumentation in and the patient fuses properly, you don't have to go in and remove the hardware after a certain period of time, because oftentimes we'll go in there with patients who have had prior fusions with the hardware, and the bone grows over encases the hardware, it becomes part of their spine. So there's no need to remove it.
And it would actually probably cause more harm to remove that hardware. You got to chisel that bone away.
It's brutal sometimes having to get that hardware out.
Get to those screws, and then there's bone into the screw head.
And sometimes you don't have the right fitting if it's done at a different hospital or something, or a different site, and you don't oftentimes know even what kind of instrumentation was used.
Yeah, I mean, they have universal hardware removal systems now that we try to utilize, but sometimes the screws are stripped.
Yep.
They're not easy to remove, and you know it's not a big deal to leave it in if you can't get it out. Sometimes the screws are actually broken. So getting them out isn't so simple. So it's you know, hardware removal might be one of the worst cases to do in orthopedics and also in spine surgery.
It's very unpleasant. So it's better if it's like the old adage, you know, if it's not broken, don't fix it.
Yeah, that's actually good advice. So in general, this patient who had the spondylolisthesis, because she had a two-level fusion with instrumentation, she was in the hospital for a few days afterward. But the discectomy patient, she left the hospital the following day.
And I think we wanted to even keep her an extra day, and she said, to get out of there.
She wanted to get out of there. She was
feeling great.
Yeah, and she was so thin she didn't have the drain came out the first day, and she was fine to go about her business right away, and she did very, very well, you know, as far as her leg pain goes. So. You know, these patients generally do very well with operations, you know, especially after they've tried everything else. And really what they needed is a decompression, because you can reach a certain point where no matter what you do, it's not helping. You've got to remove the offending agent, whether it's a herniated disc, whether there's instability of the spine, whether it's severe stenosis. You know, that's where surgeons come in. So there's always going to be a need for us.
Sometimes the problem is you know what really is the right thing, but it's hard to sometimes convince patients to accept that a lot of times. You end up feeling like you're a salesman sometimes to try to convince people. I also tell patients that, you know, it's really not an a la carte menu when you come into the office and we tell you about what we think should be done. Now, obviously, they can go and get other opinions. And with spine surgery, there can be a million opinions about what you should do, whether you should only do a laminectomy infusion, using metal and not using metal. And then sometimes patients, unfortunately, will go to what they want to hear.
Oh, absolutely.
And that sometimes is to their detriment, at least, you know, from what, you know, you see. But, you know, obviously we're not the end-all opinion of anything, but I sometimes see that a lot where patients kind of say, well, I don't want hardware, but even though you know it's the right thing to do for those patients.
Yeah, you got to trust your surgeon.
Yep.
That's what it comes down to. You know, so If you don't trust your surgeon, then you should probably find a different one.
Well, hopefully patients will want to stay with us and continue on with us.
I think so.
I think we do some good work together.
When people go for epidural steroid injections, what do you tell them? You tell them to do, because some of these pain doctors will say you have to have 3. I always tell them, that's nice, but you don't really need 3. Try 1 and see if it works. And if it works, your best shot is improvement after the first epidural. If you have a second epidural, maybe you consider that if you had some relief, but then the pain started coming back. But if you had no relief after 1 or 2 epidurals, I would not go for a third.
I think actually there was a limit. Apparently, you can only do really 3 a year, quote unquote. So although sometimes seen patients have more than that, but and that's sometimes because they're just desperate to get better without surgery. But apparently with the epidurals, over time it can induce osteoporosis.
Yeah, well, you get all the side effects of steroids.
Can cause osteoporosis.
Sure.
I think that generally the pain management specialists, at least the ones I've interacted with in the area, in the community, if they have a partial response to the first, not necessarily complete response, they will oftentimes offer a second. And if they do the second and there's no improvement, then there's a conversation whether they'll be offered a third or not. Sometimes you really just want the patient to do better conservatively, and you'll agree, okay, go for that third and let's see what happens.
Especially if they're high risk for an operation.
That's right. I mean, a lot of these patients, particularly the older ones who have stenosis, they have a lot of comorbidities. And
they're not ideal candidates for surgery. You can sometimes even do 3 every 6 months, I would say.
People in their 70s, mid 70s, what happens is that those patients actually are the hardest patients to operate on because they have had the longest period of time to develop the stenosis. So their stenosis oftentimes is severe when they come to you. And their membrane, the dura, is often very thinned by that chronic compression. So they're sometimes the most tricky patients to operate on because obviously you don't want to get a leak. So we oftentimes will try to really exhaust as much as we can conservatively with those patients.
I think an epidural has a role if let's say the patient knows they're ultimately going to need an operation, but they have some event coming up in their life. Their daughter's getting married. Something is happening with a grandchild's graduation from high school or college, and they really can't have an operation at a particular point in time. They have a vacation coming up. They've already booked a cruise or a trip. Sometimes it allows them to buy some time to get that shot before they go away. But they know inevitably, that underlying problem is still there, and they're going to need the operation. So it's something to have in your armamentarium. But like everything else, unfortunately, it sometimes just gives them temporary relief.
That's right. I think people in general realize that, but I think that a lot of people fear surgery, particularly spine surgery, because they've all heard horror stories about spine surgery from a friend or a family member. That's why it's extremely important to choose your patients wisely.
Oh, yeah. Patient selection is a key of success in spine surgery. And knowing, is that back pain coming from instability of the back? Is it coming from disc degeneration? Or is it coming because the patient's depressed?
That can happen a lot. It's about people in
they
pain
have psychological issues, and those patients are probably the hardest to treat as far as surgery, because the surgery is probably not going to make them better. They've got other issues going on.
Yes, there's a lot of psychological. There's sometimes, unfortunately, there is a bit of secondary gain to these things. So, with patients in the middle of lawsuits and such that so that's why you really have to be very conservative, I think, in these patients.
Absolutely.
And you have to make sure that their symptoms and their exam correlate with the MRI. If a patient has a herniated disc on the left side and only has right-sided pain, even though it may be a big disc, you really should.
You got to investigate that.
Yeah.
Let's say it's situs inversus.
That's right.
Their body is backwards. That's a very rare thing. But and the MRI was mislabeled, but otherwise, I would say that that's unusual.
That's very rare. Yes, I think that's quite rare.
Yeah, but it occasionally will happen that they'll have pain in the opposite leg, or they notice one side has pain, one side has more neurological symptoms, and that goes to the art of medicine, trying to figure out where's the pain generated, where's it coming from.
What's an interesting thing lately is I had a recent experience. Usually I do all my surgeries with you in the hospital, but I worked with my partner recently at a surgery center doing spine surgery where actually the patients went home that day. And they were simple problems, in essence, an anterior cervical discectomy, which is a low pain type of surgery, and they had a 1-level discectomy. And those patients went home that day.
Did they put a drain in them?
No drains.
Interesting.
And so really there's a whole range of ways surgeons handle patients, and it's becoming more and more of a trend for patients to get operated in a surgery center and go home that day. And it really made me think about, patients. They oftentimes come in and ask me, how long am I going to be in the hospital? For a discectomy, we usually say, well, usually you go home the next day, but we like to keep an eye on you that night to make sure you're okay, particularly if they have a drain, which we often do put in.
I don't think you'd ever be faulted for putting in a drain.
I don't think anybody would ever be faulted because it really is such a benign thing, and it's easily removed.
If there's a hematoma, it can be bad, especially in the neck.
And the neck, that's something I still thought about in my mind. Would I feel comfortable about that? I don't know. It depends on the actual patient and the anatomy and how hard the surgery was. But obviously, it's great for the patient to go home.
But I'm sure in that kind of a setting, you can have them spend the night in the recovery room at the ambulatory surgery center if you have any concern.
Well, that was the nice thing about this ambulatory center is that they have a whole system there. The patients can actually be there overnight and be observed. So it's really like, in essence, they're staying overnight. So I felt better about that. And I'm thinking maybe in the future we could start venturing into that kind of thing for certain types of surgery. But for a lumbar, case, I think that, most patients, particularly fusions, I think it would be very hard for me to feel like I can send the patient home, particularly with pain control. People often ask, like, how long am I going to be in the hospital for? That's one of the number one things they ask. I usually say for a big surgery like we did on that patient, I think they're going to be in the hospital 3 to 5 days because it just takes that much time to mobilize, to make sure they're eliminating, that they're eating, they're walking properly with proper balance, and they're safe and their wound is okay.
Yeah. No, it's totally true.
So I think people are okay with that and get it. I don't think they demand, I must go home that day. I think that if you can say to the patient, I think it's in your best interest to remain in the hospital and get that therapy and make sure you're safe before you go home. I think they're okay with it.
I think it's cautious. I think it's the right approach. I don't think you should be faulted for wanting to keep a patient overnight after an ACDF or a discectomy to make sure they don't develop any kind of problem. I've seen problems that have developed, sadly, overnight. And
that's the thing I would fear the most about an anterior cervical is if a blood vessel opens up in their neck.
Correct.
And they develop this massive hematoma, they wouldn't have enough time to get back to the hospital to evacuate. They could suffocate.
It could be a disaster.
It could be a disaster. That fortunately does not happen practically at all, which is great.
When I was a resident, anybody who had an ACDF would have a tray by their bed in case they developed a complication like that, so that you can immediately, we were all trained to, the first thing you do is you open the wound, put your finger in there and try to remove any clot.
I did that once as a resident. It was not a pleasant experience.
Yeah, I've never done that. And it
was crazy, actually.
Did the patient survive?
Patient actually survived, but it was just a very traumatic situation where you're at the bedside and you have this open wound right there without your tools and your cautery and everything you need to get that patient.
So you save that patient's life.
But you save the patient's life, and then you have to immediately get them back into the operating room to obviously clean them out.
And there was a small bleeder that was probably missed at the time of the surgery.
One of the things about particularly anterior cervicals, surgery, is that you have to make sure when you leave the operating room, when you irrigate the wound, it's like a martini. It is completely clear.
For us non-drinkers, that's clear.
And I always ask the anesthesiologist, exactly. You always ask the anesthesiologist, are they normotensive, meaning that is their blood pressure artificially too low because you don't want them to go back in the recovery room, elevate their blood pressure because they're in pain, and then all of a sudden a blood vessel opens up. You want to make sure they have their pressure is good, it's normal before you leave the operating room, right? So there's no bleeding.
Yeah.
That's very important.
Yeah. Yeah, well, complications can happen. That's why I'm a little tentative about doing the ambulatory surgery center, but it definitely seems like it's the wave of the future.
It seems like it's the wave of the future.
Medical economics being what it is, we'll see what happens, but I think the trend is coming more toward outpatient surgery. I mean, even total hip replacements now are being done as outpatients, which to me is shocking. Total knees.
It's amazing, isn't it? How
those patients were in the hospital for a week.
When I was a resident, at Montefiore, we always admitted patients overnight before their surgery, actually. I mean, it was unheard of to admit a patient that day for their brain surgery, you know?
Right, you had to prepare them.
And now they come in with a brain tumor that day. Usually we came in, we loaded them up on the anti-seizure medications and steroids and everything else. It's just not the way things are done now.
So now they give it to them orally before the operation? They just take it at home?
At the time of the surgery, and they seem to do fine, these patients, you know?
Interesting.
All right, so in any event, we have a lot of things to talk about.
Well, you know what? I think we should do this again.
I think we should do this again. I think we need a third episode, Spine Bro.
I think we should do one soonly.
We will do it soon.
Soonly. New word.
Nice speaking to you.
It's a pleasure.
All right.